Good afternoon. The seminar is about to begin. We welcome you to Webinar 6, Curbing Inappropriate Care, How Payment Reform Can Help, with Suzanne Del Banco and Mark Gagne, presented by the National Association of Health Underwriters Education Foundation. We hope you enjoyed the program and we thank you for joining us today. A PDF copy of today's presentation has been made available to you to print or download. You may access this document by clicking the Resource tab on the left side of your screen. You are encouraged to submit questions at any time throughout the broadcast by selecting the Forum tab on the left side of your screen. Simply type your email address in your question and click Send Question. Ms. Del Banco and Mr. Gagne will answer questions at the end of the program, and questions not addressed within our available time may be answered by way of a post-conference email. At this time, I'm happy to introduce Janet Trautwein, NAHU's Executive Vice President and CEO, and NAHU Education Foundation President.
Thank you. Well, I'd like to welcome all of you to our presentation today. This presentation is sponsored by the NAHU Education Foundation through a grant from the Robert Wood Johnson Foundation. Today's webinar is part of a 10-part series that goes through November. And our live webinar today and all future webinars are free and recorded and located on the NAHU Education Foundation's website at www.nahuef.org. Today's webinar is the 6th webinar in this series and is entitled Curbing Inappropriate Care, How Payment Reform Can Help. If you haven't viewed the past 5 webinars, I encourage you to go back and view all of them and to give us your feedback and to let others know how they can access the material. It's my pleasure today to introduce the presenters for our session. Suzanne F. Del Banco is the Executive Director of Catalyst for Payment Reform, an independent nonprofit corporation working on behalf of large healthcare purchasers to catalyze improvements to how we pay for health services and to promote better and higher value care in the United States. In addition to her duties at CPR, Suzanne serves on the coordinating committee of the Measures Application Partnership for the U.S. Department of Health and Human Services, the Healthcare Incentives Improvement Institute Board, and participates in the Healthcare Executives Leadership Network. Mark Gagne is co-owner and Chief Innovation Officer of Borislow Insurance. Located in the greater Boston area, Borislow Insurance is highly regarded as a leading employee benefits brokerage and consulting firm, serving over 350 corporate and 2,000 individual clients and more than 100,000 members in 35 states across the country. Mark has more than 25 years of experience in the healthcare industry and is a pioneer in the use of consumer-driven health and wellness plans to lower healthcare costs and improve health and well-being. Mark is passionate about the power of consumerism, health, and wellness to transform workplace culture. He's a member of the Board of Directors for the Massachusetts Health Connector and the National Association of Health Underwriters Chair of the Healthcare Cost and Quality Transparency Committee. He's a certified PPACA and self-funding expert by NAHU, and his unique ability is developing innovative solutions to complex challenges. I'll turn the session over now to Mark and Suzanne.
Thank you, Janet. Appreciate it. Welcome, Suzanne, for our 6th in a series of 10 webinars. Today we're going to have a discussion on inappropriate use of care, and as we've done in the first 5 and will continue to do, I'd like to spend a few moments just framing our discussion this afternoon. It's estimated that over 30% of our medical care in this country is unnecessary. We would deem this to be wasteful care or inappropriate care. Lack of transparency, as we've discussed in an earlier webinar, of cost and quality, is a principle-centered challenge for our country. Lack of tort reform to discourage defensive practice of medicine is also a big contributor. Absent legislation and regulation for these issues, there are other opportunities that we can avail ourselves of, and we're going to talk about those today. We're going to talk about how we can treat and pay for maternity care, diagnostic imaging, and low back pain as an example. The idea behind this webinar today is to help you empower yourself, to empower your teammates, and most importantly, to share that information and knowledge with your customers to help them become better educated so that they can lean on these tools and resources to be better, more informed healthcare consumers. So with that, I'll turn it over to Suzanne, and as we've always done, we'll go back and forth throughout the presentation, and then at the end, we'll save some time for questions. So if you have them, please feel free to go ahead and email them as we talk along.
Thank you, Mark, and thank you, Janet, and thanks to NAHU for involving us in this webinar series. It's been a lot of fun, and I think really a great opportunity to talk about ways in which we need to work to help fix the healthcare system and the role that brokers can have in that. And today we're going to talk about a topic that is obviously very, very important, which is that we are spending too much of our healthcare dollars on waste and inappropriate care. And when you think about how expensive healthcare is and how costs just keep going up, it is kind of a crime, that we have a situation where we have people getting care that they don't need, and especially because in some cases it can even be harmful when they get care that they don't need. And so our theme today is really to address that topic, talk about how payment reform could help curb inappropriate care, and also give you some very concrete examples of where care is often inappropriate today and how payment reform in those specific domains might actually help address that care that is inappropriate and get care to be closer to what the clinical guidelines suggest should be delivered. So today we'll be talking about how it affects our spending and then delving into some specific examples of maternity care, imaging, and spinal surgery. And as usual, I look forward to Mark interrupting me with all kinds of comments and questions. So, you've probably all heard this, that the U.S. healthcare system spends more than any other country per capita, meaning per person. Yet we have worse results than many other countries. And this slide here just shows how we spend 2.5 times the OECD average. There are many countries whose healthcare systems we respect who spend less than we do. And it's, a real travesty that we're spending so much, but we don't have that much to show for it. And I think, when you think about the U.S. healthcare system, people say we have the best healthcare system in the world, and that's true, I think, for when people have, really challenging health conditions. The technology and the science and the advancement here in medicine is unparalleled, but that doesn't mean that on, more pedestrian services that people need on a daily basis or that maybe aren't as drastic, that we're getting the right care at the right time in the right way for the right patients. And so we have a lot of work to do on that. So not only are we spending far more than others, but this next image illustrates that we also are not living any longer than other countries who spend far less than us. And in fact, when you look at the number of countries here to the left of where we are, you can see that there are many countries that are spending less since we were the highest spender, and yet people are living longer. And in fact, we're worse than the OECD average, and that's really kind of embarrassing. And again, while life expectancy is increasing around the globe, it's not necessarily because our healthcare system in the U.S. is contributing to that average. So the other thing that we're going to be talking a lot about today is the concept of overtreatment. So not only are we spending a lot in ways that might be futile, but we know that some of that spending comes from the waste of subjecting patients to care that can't possibly help them. This might be care that is following outmoded guidelines, not the current guidelines. So, for example, doctors who are still encouraging women to get pap smears every year, even with normal results, or mammograms every year, even if they don't have particular risk factors and they're under 50. We have it due to supply-driven behaviors. The Dartmouth Atlas has shown that in areas where you have more orthopedists, for example, there's more orthopedic surgery, and it's not because, thank goodness, there's access, but it's because the supply actually drives demand. And in some cases, we just have ignoring of science or the lack of dissemination of what the latest science shows. Some have said that it takes about 17 years from the time that there's a scientific advancement to the time that it really penetrates broadly into the practice of medicine. And so for all these reasons and others, there is a lot of overtreatment. And when you look at how it contributes to the spending in the healthcare system, it's only it is the one of the leading causes of spending, and only administrative complexity, and fraud and abuse, come close to how much this is contributing. So it's an area where we need to spend a lot more attention than we have. Sorry, I'm having a little bit of a delay here in seeing my slides, so pardon the pause. So the question today is, how can payment reform help address this issue? And we're going to be talking about a few different types of payment reform, so just reminding you what these are before we get into the details. We're going to talk a little bit about global payment or capitation. It's the idea of paying a set amount of money per person for a given amount of time. And what can be helpful about that is that since the amount of spending per person is capped, there are financial incentives for providers to not deliver care that's not needed, because if they do too much of that, they could overspend the amount of money they've been given to take care of patients and, work at a financial loss. So there are some arguments that if we had more global payment or capitation, rather than the fee-for-service system we have today where we pay for every unit of service, and some argue that it's inherently inflationary, it leads to more care and more expensive care. If we were to switch to a different set of incentives that global payment and capitation bring, we might be able to curtail some of this overtreatment. On a smaller scale, but in a similar concept, bundled payment could do the same, where there's a single payment made to healthcare providers or facilities for all the services that a patient needs for a given treatment or condition or episode of care. And likewise, since there is a cap on how much is being spent per episode, providers will have less of an incentive to overspend or overtreat, and in fact will try to provide the minimum care possible to still perform well on quality measures and also patient outcomes, in addition to staying within the budget. A third type of payment reform that we're seeing increasingly in the market today is shared savings or shared risk. So we've heard a lot about the accountable care organization movement, and most accountable care organizations today are supported by a shared savings model, and many are on the path in the next few years to get to shared risk. And the idea is that these are payments to providers and suppliers who get to share in savings if they meet quality standards and beat some kind of spending target that has been set for them. The idea of shared savings is that you get to share in, the benefits of spending less. Shared risk is more like what you heard about under global payment and capitation or bundled payment, where if there's overspending beyond some kind of budget, the provider has to eat those costs. And so there's a good, strong incentive not to do that. So all three of these payment methods, provide examples of how moving from our traditional fee-for-service payment model to methods where there is some kind of budget set can help curtail inappropriate care. So with that as background, we are going to move into talking about some specific examples of where there's overtreatment and where payment reform could conceivably help. So the areas that we're going to be talking about are maternity care, diagnostic imaging, and spinal surgery. And I think each of them, you're going to see similarities in some of the issues that underlie the overtreatment in these areas, but some of them have some differences. I think as background, it's important to keep in mind why maternity care is so important. At least the organizations that my organization works with are big employers and many state Medicaid agencies, and labor and delivery account for a huge number of the hospitalizations that those populations experience. And in fact, as you probably know, when labor and delivery services go well, it's a happy occasion. When they don't go well for whatever reason, it can be very devastating and extremely costly. One example of where there have been problems in overtreatment is in women who are getting elective deliveries, either the inducement of labor or a scheduled cesarean delivery prior to the baby being fully ready to come out, so between 37 and 39 weeks of gestation. And that's an example of where there's too much intervention, and this can lead to complications for mother and baby from a health perspective, as well as greater costs. Another area that we'll talk about is diagnostic imaging overuse, so people getting some kind of x-ray or scan to help diagnose some kind of ailment that they have. And this is particularly true for patients who have back pain or headaches. And there are other issues surrounding this, in addition to too much imaging, just as a course of not being adherent to guidelines on the part of providers. You also have providers who own the imaging equipment and are making self-referrals to their own equipment where they stand to gain more revenue as a result of people using that equipment. Now, there have been sunshine laws passed that require disclosure of that ownership, but that's not necessarily being enforced on a broad scale. And it's also not necessarily going to sound like a conflict of interest to a patient who typically is going to listen to whatever their doctor suggests is best for them. But there may be cases where these self-referrals are either unnecessary or are self-referrals to more expensive imaging centers than the patient might have access to elsewhere. And then lastly, spinal surgery. This is one of the costliest and most overused surgical procedures in this country. Lots and lots and lots of human beings suffer from back pain. And there are many alternatives to try before resorting to surgery, but sometimes patients get shuttled into that scenario pretty quickly. And unfortunately, not only is it expensive, but for some patients, it's just not going to be helpful and, in fact, can lead to further problems. So this is an area where there's been more scrutiny recently and where there continues to need to be more scrutiny. So, Mark, let me just pause here and see if there's anything you want to add.
Yeah, no, I think in the three areas, if I just touched on maternity care, I definitely see with our clients a spike in more elective type deliveries. I think the only time it's probably, I shouldn't say this, I'm not a physician, but the only time it's really probably appropriate when you're having electives, as an example, elective cesarean, might be if there's, extenuating circumstances, higher risk pregnancy as an example. As it relates to diagnostic imaging overuse, I think if we had more transparency, which we're going to talk about in a little bit, if we had more transparency in the area of physicians owning their own imaging equipment, I don't think it's about them owning their own imaging equipment that's the problem. I think it's about the lack of disclosure of the actual cost, because if my provider, as an example, owns his own imaging equipment, that it's half as expensive as somewhere down the road that he used to refer me to, that's not necessarily a bad thing. And then in the area of spinal surgery, I grew up in a family of healthcare providers, and my mom and dad was a physical therapist, mom was a nurse, always used to tell me surgery ought to be the very last thing that someone considers. So I absolutely agree with you that there's a problem here with reaching too quickly for the knife, if you will.
Thanks, Mark. And Mark and I might disagree a little bit on the ownership of imaging equipment, because I agree transparency could be the solution, but even if the price is lower, it's still revenue that the provider could be generating for him or herself, and I think there's an inherent conflict there. But, that's something that we can look at empirically to try to understand over time. So when it comes to maternity care, let's delve into that a little bit more. There are very clear guidelines on when it comes to a pregnant woman and labor and delivery, when a woman needs intervention and when a woman does not need intervention. And unfortunately, those guidelines are not fully adhered to. And this has resulted in not only too many early elective deliveries, which I was just referring to a moment ago, but also too many medical interventions in full-term delivery, whether it's fetal monitoring or cesarean delivery or inducement of labor. And the downside of all of this, even though for the most part all these things are relatively safe, is that there's a reason why evolution sort of designed birth the way that it did. And unfortunately, when babies are born through cesarean delivery, which is often a result of an inducement, by the way, because inducements often do end up in cesarean delivery, it means that the baby is more likely to have respiratory problems and more likely to end up spending some time in the neonatal intensive care unit. And of course, having surgery is often more risky than a regular vaginal birth, not to say that there aren't risks with that too. But what we're finding is that in the world of fee-for-service medicine, where we pay for each unit of service separately, there are financial incentives for providers to intervene where they may not need to. Now, let's just take a moment here, though, to recognize that there are other incentives that have led to these practice patterns. There are patients who do demand to have a cesarean delivery at a scheduled time, for example, and so in some cases providers say they're just bowing to the pressure from their patients. We also know that there are convenience and lifestyle issues for the physicians that are at play. It may not make a difference to them to earn $500 more or less, depending on the type of delivery, but it also means that they can control their life more if things are scheduled. And so even though I truly believe that healthcare providers, go into their professions because they want to help people, including OBGYNs, we're all human beings and subject to different types of incentives. And so the bottom line is that the practice patterns haven't been being followed as closely as they need to. And unfortunately, we've had worse outcomes and higher costs as a result. And now we'll get into a little bit more detail on that. So one thing I will comment on is that the cesarean delivery rate is somewhere around 33-34% right now. And that means, 1 in every 3 births is being delivered through surgery. And the WHO, the World Health Organization, says that the sort of natural rate of cesarean delivery, in terms of medical necessity, should be somewhere between 5 and 10%. And frankly, anything above 10% would cause harm. More harm than good, I guess is the best way to say it. Even the Healthy People 2020 goal, which is only, 4.5, 5 years from now, has set the cesarean delivery rate at 24%. And that was based on knowing where the country was and what could be feasible to get to, not necessarily what the ideal cesarean rate is. But the bottom line is that we are far above where we should be. And, we have not really seen much change in it, even over the last 5-6 years, that there's been a lot more publicity around the fact that early elective deliveries are harmful, et cetera. So in addition to that as background, the other thing that you might imagine is that it is more expensive to have a surgical birth than a regular spontaneous birth. And in most cases, cesarean deliveries cost about 50% more than vaginal births. You can imagine all the attendant services and resources that are needed for someone in an operating room as opposed to in a labor and delivery room. And so the charges are much higher and the paid amounts are much higher. This is also true in Medicaid, where often they're paying slightly less than commercial rates, but still they are paying much more for cesarean deliveries than for vaginal births. And so when you pay more for a certain mode of delivery, I guess we shouldn't be that surprised that it's happening more often. And so immediately, I'm sure your brains are clicking away, thinking about how payment reform could be useful here. And so, right now, as we pay for each unit of service and each office visit, et cetera, we are paying more than we need to. And there's also too much intervention. And so we need to change the incentives. And an example of a change could be for taking the difference between cesarean delivery payment amounts and those that we pay for vaginal deliveries and creating a blended rate that would make it more profitable for a provider to do a vaginal delivery than it's been and less profitable to do a cesarean delivery. That's an example. Another example would be a bundled payment where there is a set bundled amount for births, regardless of the mode, and it sort of would function the same way as a blended rate, except that this would be paid prospectively as opposed to retrospectively. Regardless of how we pay, the key is to try to reduce the perverse financial incentives for intervention when it's not needed.
Suzanne, before you advance, I wanted to ask one question about this. Have we seen, with the increase in cesarean deliveries, have we seen any impact on infant mortality rates?
That's a great question, and I should know the answer. I know that in California, there was research being done, believe it or not, into higher maternity mortality rates. And that there had been a growth in the mortality of mothers delivering babies, and they were trying to understand why, but it did seem to correlate with greater intervention. They had accounted for older age of mother and other things like that. So there was some concern about that. I don't know what the mortality differences are between vaginal and cesarean delivery for the babies. I just do know that the babies who are born via cesarean are more likely to have respiratory problems and spend more time in the NICU. So, I would guess that that's correlated with a higher mortality rate. How much, though, I don't know.
Okay, great. Thank you.
So this slide just shows an example of the blended model I was referring to, where if you were to pay a blended amount retrospectively or a bundled amount prospectively, regardless of the delivery mode, you could remove the financial incentives for cesarean delivery. So if you look at on the left side, where the current cesarean delivery rate is 32%, and we're paying more for cesareans than vaginal, if you were to come up with a blended amount that was somewhere in between them, you might get there to be some change in the practice patterns. Another way to think about setting a blended payment rate is to put in an aspiration. So if the provider were to have been delivering cesareans at 24% of births, like the Healthy People 2020 goal, rather than at 34%, and you were to assume that total amount of revenue would come into the providers, as well as the total amount of revenue for the vaginal births for the remaining, what would that be, 76% of births, and come up with a blended amount that would make them whole at that rate, then you see that the blended amount is slightly less than it would have been at the 32% rate. So I hope that makes sense. But the idea is you can kind of build an aspiration for what the cesarean delivery rate would be into the blended payment amount or into the prospective bundled payment amount, and create incentives, again, pressure on the providers to really support labor and to support vaginal delivery where it's medically feasible, so that the outcomes are better, the expenditures are lower, and we end up with better value for our healthcare spending. So I'm just advancing my slides here. Sorry, it's a little bit of a delay. I wanted to make a bridge from this into something that I think we've mentioned before in this series, which is the Choosing Wisely campaign. And this was a campaign started by the American Board of Internal Medicine. They encouraged specialty groups of physicians to think through whether or not there were any services they were providing to patients that were unnecessary. What services were they doing too often? What really fit into that category of overtreatment? And then to start a campaign of education for patients, so that if a provider suggests to the patient that they should, for example, have an early elective delivery by cesarean, the patient could question and say, well, wait a minute, doc, is this really the right thing for me? So obviously we don't want to put all the onus on patients asking questions, but it has been a good step forward for these specialists and specialty groups to identify aspects of their practice where they're doing too much. And so when the American College of Obstetrics and Gynecology put out their 5 recommendations, you can see on here some familiar topics from what we've just been talking about. So they said don't schedule elective, non-medically indicated inductions of labor or cesarean deliveries before 39 weeks of gestation. Don't schedule elective, non-medically indicated inductions of labor between 39 and 41 weeks. That means, a woman has passed her due date, potentially, unless the cervix is deemed favorable. Because in other words, if you induce labor when the cervix is not favorable, it's not going to progress, and there's no point in doing it. Don't perform routine annual cervical cytology screening like Pap tests in women 30 to 65 years of age. So that's, the new guidelines say once every 3 years, and many people are still doing it every year. In fact, I know of a doctor who said, well, if your insurance will cover it, why not? Talk about overtreatment. And don't treat patients who have mild dysplasia of less than 2 years in duration. And don't screen for ovarian cancer in asymptomatic women who have average risk for it. So these were 5 guidelines, as an example, in the Choosing Wisely campaign that ACOG, the American College of Obstetrics and Gynecology, came up with, that if they were followed, we would have less overtreatment and less unnecessary spending. Mark, do you want to add anything before I go on from here?
Yeah, so there are actually 2 questions that, are really easy for people to ask. I agree with you that we don't want to put too much burden on the patient or the consumer, but at the end of the day, an informed consumer is the best thing that we could possibly hope for. So asking the question as an example, how many people out of 100 like me, doctor, has this helped? And conversely, how many people like me out of 100 has this harmed? Those 2 simple questions right there, if a physician is not able to answer those questions, then the patient should ask, well, I need to know the answers to those questions before you determine what the appropriate treatment plan for me is. So just piggybacking on top of Choosing Wisely, those questions can be as simple as the 2 I just mentioned.
Yeah, that's right. And we'll cycle back to Choosing Wisely in a moment. So, the audience today are brokers, and I know you're thinking, okay, well, what can I do about it? Well, let me just give you an example of one thing that CPR has been doing. That's my organization, Catalyst for Payment Reform, with the health insurers. We have quarterly user groups with health insurers, and every quarter we ask them to report to us the total dollars paid for maternity care to hospitals with contracts that provide incentives or disincentives related to adhering to clinical guidelines, which, if they were followed, would reduce unnecessary elective medical intervention during labor and delivery. And to tell us that amount out of the total dollars spent on maternity care at hospitals. And so what we're basically getting at is, out of all your spending on maternity care, how much of it is going to providers with which you have created contracts that have some kind of incentives around the payment for adhering to the guidelines. And this is an example of something that you could be asking on behalf of your customers to find out what the health plans are doing. To be honest, what we started doing in addition to this is also just asking for them to report to us their cesarean delivery rate. Because we've had a fair amount of pushback on payment reform in the maternity care space. And so we said, well, if you have some better way to do it, like some of the health plans have said, what we're doing, we're spending a lot of time on patient education, or we're educating providers. And we say that's all very nice and well, show us that it's working. And we have not seen the cesarean delivery rate budge yet. And so we're continuing to keep the pressure on when it comes to payment reform, because it really hasn't been fully explored in the way that it needs to be. So in addition to that, we also did a case study, which we thought could be very helpful to the world at large, on South Carolina. And let me tell you a little bit about what happened in South Carolina. So in South Carolina, the governor recognized, the director of Medicaid recognized that there had been too high a rate of early elective deliveries in the state, and that there were many things going wrong with maternity care services that needed improving. And so he pulled together every stakeholder in the state involved in maternity services and said, we've got to make a change here. So they called their effort the Birth Outcomes Initiative. They had several different aspects to it, including a focus on reducing early elective deliveries. And they spent some time with providers just working on quality improvement. And so they had all kinds of collaboratives and learning sessions and education about guidelines, and they did make some progress. But what happened was the providers who were really game to get on board and to modernize the way that they were practicing maternity services couldn't get some of their recalcitrant colleagues to come along. And so they came to Medicaid and said, you know what, the only way this is going to get to where it needs to get is if you stop paying for early elective deliveries entirely. And so the Medicaid program and Blue Cross Blue Shield of South Carolina paired together, and they agreed to implement a non-payment policy for early elective deliveries. And the two of them together cover 85% of the births in the state. So you can imagine how influential that was. And the results have been extremely positive. The rates of early elective delivery have dropped to an all-time low. And of course, the payers involved are saving money as a result. And so that's a very exciting example. I'll give you another example in the state of Oregon, in Portland. 19 hospitals there agreed, really honestly out of goodwill, to all simultaneously stopped performing early elective deliveries. And of course, that led to a massive change very quickly that didn't require payment reform. But given that not all providers are as progressive as those hospitals in Portland, payment reform is definitely an approach that can help focus the attention of providers who are not adhering to the guidelines. Mark, is there anything you want to add here before we talk about the resources available to educate?
I wanted to ask you a little bit about Oregon. Was that brought about by the providers themselves, by the employers, self-funded employers in the marketplace? What was the impetus behind that change?
Yeah, my understanding it was actually the providers that they looked at what the evidence was showing and the fact that the rates were getting high, and they felt like if they didn't all simultaneously do it, providers who wanted to continue performing early elective deliveries would just shift which hospitals they admitted to. And so they agreed that they needed to kind of create no escape and banded together to work on it.
Wow, great. Thank you.
Yeah, it's exciting. A good model. Another thing that is important, of course, in all of this is for expectant mothers to be educated and fathers too, frankly. The March of Dimes has put together a wonderful toolkit on materials that employers can share with expecting parents and information on why it's worth the wait. They had a whole campaign talking about why it's worth the wait to try to encourage mothers to wait to deliver their babies until they are full term. So for all of you, these resources can be very helpful. They're downloadable and very attractive, and it's something that you can connect your customers with, and I think could be a very helpful element of trying to make progress in this space.
To my broker colleagues dialing in, you might want to favorite those. They are great resources. So,
yeah. So now we're going to make a transition from maternity care to another area of where there's been overuse, although it was much worse 10 years ago than it is now. Diagnostic imaging is still representing about 6 to 8% of total U.S. healthcare spending, and it's still a rapidly growing category of overall spending, even though it's less than it used to be. But the thing that's really remarkable is that when asked, radiologists say about 30% of the imaging that they're performing or examining is unnecessary. And so let's take a look a little bit more into detail about that. One of the factors driving overuse, or multiple factors driving overuse, have to do with ignorance of what specific imaging studies are needed and when, and high public expectation for imaging tests. In other words, patients saying, "But doc, I need an X-ray, or shouldn't I get an MRI or CAT scan?" There is some element of it that's related to defensive medicine, meaning doctors wanting to make sure to protect themselves by not missing something that they could get sued about later, or fear of a misdiagnosis. And then also, frankly, because there has been an increase in consolidation among healthcare providers, meaning hospitals merging with each other horizontally, or health systems or hospitals purchasing physician groups, the imaging centers are often now owned by whatever the provider group or system is, and therefore the same kinds of conflicts of interest that Mark and I were talking about toward the beginning of this discussion come into play, where there are concerns about self-referrals where they may not be needed. And all of this has led to overuse of diagnostic imaging, X-rays, CAT scans, MRIs, and overuse in this case means an application that's unlikely to actually improve patient care. The other thing that comes about with all of this is identifying, images that suggest that something could be wrong with a patient that were not anything related to what the patient was complaining about. And so it leads to a whole vicious cycle of testing and additional care that may not have been needed in the first place. So that is very problematic, and of course leads to a lot of anxiety on the part of patients that may not have been necessary. So given that imaging is a significant area of spend, and it's often done when it's not needed to, what can be done about it? Well, let's look at an example in Massachusetts. my original home state and where Mark lives now, where Blue Cross Blue Shield is about 5 years into something called the Alternative Quality Contract, where they're paying provider groups an annual risk-adjusted global payment for each member. So if you remember back at the beginning of this discussion, I talked about global payment or capitation as being a single payment for all the care that a patient needs in a given period of time. And that's what they're doing here. So beginning in 2009, they found, as this program was getting implemented, that spending on imaging services decreased. And in fact, it decreased by almost 11% over the 4-year period for providers in that program. And about a third of the savings were from fewer tests being ordered in the first place. And you recall that I talked about the incentives that come with getting a set payment. You question whether or not something's necessary, because for every ounce of care that you provide, you're eating into the budget that you were given for a given patient. So you take a moment to think about it. And of course, this needs to be balanced by quality measures to make sure that patients aren't being harmed by care being withheld from them. But if it's done right, and there have been some successes shown from the Alternative Quality Contract, then you can have some good results. And I know Mark's probably going to want to chime in and talk about how everything in Massachusetts is overpriced, and it's not like the care through the Alternative Quality Contract is as cost effective as it could be. But I think what's important here is that within a controlled environment, by changing the method of payment, we saw a reduction in overtreatment. So Mark, is there anything you want to add to that? And sorry to preempt.
Oh, no, that's okay, Suzanne. I mean, we did talk about it in our preparatory call, so I'm happy to just share my point of view here, since this is something that I live in every day, given the fact that many of our clients are covered by Blue Cross Blue Shield in Massachusetts. When they originally rolled this out 5 years ago, the AQC, I asked the question, how is this not global capitation under a different name? I was quickly corrected and said, well, it's not really global capitation, Mark, because there's a quality component to it. I'm not going to debate that. I think we could debate that, but not in this setting and for today. What I would like to say is, the AQC has had some success, but I don't want anyone on this webinar to think it is the be-all, end-all. I'm not suggesting you're saying that either, Suzanne. What I would say to you that in our market, trend is still substantially higher than the United States average, and our per capita spending is the highest in the entire country. So while AQC may have been on a laser issue with regard to imaging, as an example, decrease the level of utilization, I'm not so sure it's a model for the rest of the marketplace or for the rest of the country. But I do think there is some merit in the imaging, the use of it in imaging.
Yeah. I mean, the one thing I will say, having reviewed the literature on every ounce of payment reform tried across the country recently, this is one of the most promising programs that there has been. And again, it's not necessarily getting prices down to where they should be, but it is showing that by changing a method of payment, you can improve quality in certain areas over time. And I think that's, very promising and something that we want to continue to experiment with and explore in all kinds of markets. And there's no question that in Massachusetts, part of the problem is the consolidation of providers and some very, very dominant providers who are able to command, much higher prices than would be really competitive. And so, it's a tough market. So moving beyond the Alternative Quality Contract, though, I just wanted to share a few other thoughts on imaging and what could be done in this space. So, the U.S. does spend more on spinal surgery for low back pain than any other operation, $13 billion in 2011. That's the most recent year for which we could find data. So some types of interventions that have been working, Blue Cross Blue Shield of North Carolina now requires 3 months of non-surgical treatment or physical therapy before surgery. And as a result, they saw a 30% decline in the number of procedures performed in the first year. And that shows you that people were jumping too fast to surgery in the past. And Walmart, a company that is part of CPR, offers employees spinal procedures with no out-of-pocket expenses if they are willing to go to centers of excellence. And the centers of excellence also found that 30% of the procedures that employees thought they needed were actually inappropriate. And what Walmart did is they set it up so that they are willing to pay all the expenses for someone to go to a Centers of Excellence to have a proper evaluation, and they pay the Centers of Excellence independently for that evaluation so that they, gain revenue regardless of whether the surgery happens. And they found that by having these really well done evaluations, that about a third, like in North Carolina, were actually unnecessary, and the patient went home without having the surgery done. So I think that's a very, very positive result, given that no one wants to go through surgery when they don't need to, with all of its risks, and that hopefully these people found alternative ways to reduce their pain and to become more mobile. But at the end of the day, reducing unnecessary surgery is a good thing.
I'm sitting here smiling, Suzanne. You can't see my face because, again, growing up with a dad who is a physical therapist and reminding me often that surgery should be the very last thing you do. It's nice to see physical therapy be listed as a place people ought to go. I also would suggest complementary and alternative medicine. Somebody who suffered with back pain since his early 20s, some of it self-induced through some of the sports I played, but nonetheless, back pain. I do know that taking advantage of massage, of chiropractic, of acupuncture, in addition to physical therapy, those less invasive forms of care not only are less costly, but they're much more beneficial to the individual. So.
Yeah, and of course there are times when people do need surgery, and all of this that we're talking about today is really about making sure that people who don't need care don't get care. But of course, we still want to maintain access and the right care for people for whom it's medically necessary to intervene somehow, whether it's in the maternity space or in low back pain. So I'll just make a more general comment here from the National Academy of Sciences Institute of Medicine that they thought about what were 5 areas of competency that all health professionals should exhibit, and this relates to this idea of inappropriate care and overtreatment. All providers should be able to deliver patient-centric care, putting patients at the center and not having their care really be for their own revenue generation or convenience. That they should all be working as part of interdisciplinary teams, taking advantage of, social worker when needed, or nurse practitioners or others, primary care physicians as well as specialists, to make sure that the patient is getting the right level of care and not intensifying it unnecessarily or prematurely. That they should all be practicing evidence-based medicine. And, unfortunately, it's easier said than done. There are very clear guidelines out there for the vast majority of care that people need. But we can see again and again, no matter what area you look in, whether it's maternity, low back pain, or asthma, or diabetes, or anything else, that unfortunately the guidelines are not being followed as often as they should be. And I think we've shared with you the statistic before, a study that was done a good 10 years ago, show that for patients with the most common chronic conditions, they only get the right care according to the guidelines about half the time. So we really have a long way to go on evidence-based medicine. I think with, the increase in the availability of electronic health records and computer physician order entry systems that check for mistakes that providers make and question things that they're ordering, we are going to get closer. I think technology will help here, but we are still needing to make progress on many, many fronts. Also, another area of competency, of course, is a focus on quality improvement, the ability to measure quality and see where one is and improve upon that is absolutely critical in terms of a competency for a health professional. And then speaking of information technology, the ability and willingness and action to incorporate information technology into the delivery of care has been shown in many, many cases to improve the quality of care and in some cases the efficiency. We're still at sort of an awkward adolescent stage with information technology in healthcare, but there's no question that we have to incorporate it and use it to the patient's advantage over time. And the thought basically is that if all of these competencies were followed and were adhered to by healthcare professionals, we would obviously substantially reduce improper maternity care and the overutilization of medical technologies such as imaging. So I think going back to the basics and the sort of core characteristics we want our healthcare professionals to have, we would go a long way. But one of the things that I've learned over and over again is that relying solely on professionalism in healthcare is not going to get us to home plate. Unfortunately, professionalism alone doesn't do it. Transparency can help, measurement can help, and incentives can help, and that's why we're talking about how payment reform needs to be used to address this area. Mark, is there anything you want to add before I make my next comment?
I was going to ask you if you think it's an issue of providers, medical providers, not wanting to be measured. I've often heard physicians say, well, what I do is more of an art than a science, which I kind of look at that and say, well, no, it's really a science, but I'm not a doctor. But I would like to suggest, I wanted to ask you a question. Do you think it's more doctors not wanting to be measured by what they do, patients not having the right information walking into a discussion with their physician, or is it a combination thereof?
Oh, I think it's a combination of so many factors, even more than you've listed. I think that there are some providers who very much like to be measured and get that feedback, especially if it can be done privately where they can incorporate it and have a chance to improve before anyone sees it publicly. I think there are others who believe and who have been very supportive of public reporting on performance, because they know that there's nothing like sunshine, to increase everybody's focus on making sure that the quality of care is good. And I know that from my prior role as the founding CEO of the Leapfrog Group, where we were the first organization to pioneer having hospitals self-report on their quality and safety practices, that it got people's attention. It went right up to the level of the board of trustees at hospitals that they needed to start focusing on improvement in the areas that we were asking them to measure, because when it's public, the last thing you want to do is to be the worst in the group, and it really helps focus attention. I think on the part of patients and consumers, we have a long history of assuming that whatever doctor we've chosen is the right one, that they're good, that they're going to do the best. We want to reassure ourselves that we've made good decisions, so we tend not to question. And I think that's changing. More and more you hear about patients coming in, having educated themselves on the web, coming in with reams of papers, or sharing their iPhone with their doctor to say, hey, but I read this. So I think things are changing. But it's overwhelming. I mean, healthcare is so incredibly complicated. I've worked in it my whole career. I'm not a doctor, and I know enough to be dangerous, but I also don't know that much. And so it can be very hard no matter how much work you've done. You still go into the doctor's office, you question something, the doctor gives you an answer, and that's it, end of discussion. And so it's still not quite at the place where even when patients feel empowered, they can sort of follow through to the nth degree easily. So, I think it's a combination of those things. It's also, of course, knowing me, you would expect this, that I would say that the way we pay for care is also contributing to overuse and inappropriate care and overtreatment, because we are willing to pay for it. And if we're willing to pay for it, someone's going to deliver it. So I think, that's another component.
So how do you think we can begin to change the culture of doctors and medical professionals who become accustomed to overusing services and testing, as an example?
Well, I think we're already changing things. There's it's only in the last really 13, 14 years that we've had any quality measurement that's been publicly reported, and that makes a huge difference. We also really just in the last 4 years have had greater price transparency, or I shouldn't just say greater, have had any price transparency, so we can see what we're paying for care. The use of information technology, as I mentioned, I think is going to really help revolutionize the way that healthcare providers deliver care, because they're going to have constant cognitive support, reminders of what they're supposed to do, and flags when they try to do something that's not on the guidelines. And patients are becoming more and more empowered and more equipped to ask the right questions. The Choosing Wisely campaign being an example of where, there are toolkits to help educate employees and just consumers generally about the overuse of healthcare, how to ask their doctors questions. And there are, specific sets of questions on myriad conditions and types of care, so that if someone is, a cancer patient, or they need something done to a joint or whatever, there are specific sheets that they can look at and print out and come to the doctor's office equipped. So I think all of this is going to help limit the overuse of medical care. And it's going to be a question of time, and it will never be perfect, I'm sure, but I feel like we are moving in the right way.
Great, thank you.
So the slide that I'm showing you all right now shows a link to a Choosing Wisely toolkit that was specifically engineered for employers. So in addition to the education sheets that the American Board of Internal Medicine Choosing Wisely campaign put out with, in partnership, I should say, with Consumer Reports, there is a special toolkit that was created by the ABIM Foundation, the National Business Coalition on Health, the Pacific Business Group on Health, and Consumer Reports to help employers implement and educate their patients about what Choosing Wisely has to say in the workplace. And so I encourage people to take a look at it. I think it's very useful. It's free. And again, to the degree that you want to educate your customers about overtreatment, overuse, this toolkit could come in very handy. As an example, I was sharing that there are very specific Choosing Wisely tip sheets on particular clinical areas. And so as an example, there's one on imaging tests. What questions should a patient ask a doctor who's ordering an imaging test? And so if you want to see a very specific one, in the PDF of our presentation, there'll be a link you can click on that will show you that example. And Mark, I think I'm going to hand it over to you to talk about sort of, this in general, what you've heard and what you think the takeaway should be from the broker's perspective.
Okay, Suzanne, thank you very much. I appreciate that. I think we've talked about a lot today. This webinar today, but all 6 of them now that we've completed are really filled with rich content and a lot of helpful resources that we can take back to our clients to help them. I think a couple points are worthy of mention as we wrap up our formal part of the presentation and then see if there are any questions that our members would like to ask. First is inappropriate use and overuse of care is a big problem in the United States, as Suzanne has taken us through in great detail. We all know that a lack of transparency, we've talked a little bit about tort reform, not a lot, but there is an impact of tort reform in the defensive practice of medicine, and frankly, poor consumer education are leading causes to inappropriate use and overuse of care. We believe the combination of personal responsibility, education, transparency, and payment reform are all very powerful principles to make real change in healthcare cost and quality. Suzanne talked about today a number of targeted reforms that could be very helpful. As an example, bundled payments for maternity care. I'm suggesting transparency or greater level of transparency for imaging and clinical protocol to encourage, as Blue Cross of South Carolina has done, or North Carolina, I think it was mentioned, clinical protocol to encourage less invasive forms of care like physical therapy and complementary and alternative medicine for back pain. These are some examples of targeted reform or targeted programs that can really make a big difference on cost and quality. I think the big takeaway here for my broker colleagues listening in is it's important that you invest time educating yourself about the types of tools that we've talked about today. So when you're having a consultation with your client, that you're able to provide these tools with them and really go beyond just providing the insurance coverage, but go deeper into helping them become educated and informed healthcare consumers by educating yourself, educating your team, and most importantly, taking the time to educate your customers using the NAHU Education Foundation's webinar series as a reference point. You can use the tools that were referenced today, bookmark them, so that you can share them with your clients so that ultimately they can become more informed, more empowered consumers. So with that being said, I'd like to see if we have questions that we can walk through, Suzanne, for at least a couple minutes. The first question was a really simple one. That was, what does the acronym OECD stand for?
Someone would ask me that. It's the organization. Hold on, I'm going to have to look it up. It's a term I think used by the World Bank. So hold on one sec. It's the Organization for Economic Cooperation and Development. Yeah. So I wish I could remember where it comes from, but it's certainly sort of an international, global term used for countries who I think are working together on understanding the global economy and how to develop it.
Excellent. I know that we had talked a little bit today in our discussion about defensive practice of medicine. I know I'm familiar with one state, Texas, has actually implemented some level of tort reform. Are you familiar with what Texas has done? And has tort reform really done anything to reduce the amount of defensive practice of medicine, in your opinion?
Thanks, Mark. I have not followed tort reform that closely in recent years. I did more when I was at the Leapfrog group because, when we were focusing there on preventable medical mistakes, it obviously was closer and more connected than it is with payment reform. What I will say is that the odds of lawsuits being successful are greatly exaggerated in the eyes of many providers. And so it doesn't mean that there doesn't need to be tort reform. Clearly, in some places there does. But what has been fascinating to see is that the perception of providers on the likelihood of a successful lawsuit against them is much greater in many cases than it actually is. And so one of the things that this leads to is some of this defensive medicine when it's probably not proportional to the risk. So an example would be the fact that it's very difficult for women to find access to hospitals who will perform vaginal births after a woman's already had a cesarean because there's fear of rupture and hemorrhaging. But the risk of that, clinical complication is actually very low. And the proportion of lawsuits that have ever been filed or won in that area is minuscule. But yet it can be extremely difficult in some markets for women to find access to anyone willing to do it, even though the medical evidence suggests that it can be quite safe. So I think that's a good example of where the fear of lawsuits is greatly exaggerated and has affected practice, even if it's not commensurate with the reality.
And I don't disagree with that point. I would say to you though, if you're a practicing physician, buying malpractice insurance can be very, very expensive. So while the reality of being sued may not be as great, the reality of success, or in the case of a physician, failure, or being sued and having successfully being sued against, may not be that high. The reality is the cost of malpractice insurance is going through the roof. I mean, as an example, orthopedic surgeons have to work, my friend told me this, somewhere between 3 and 4 months out of the year just to pay for their malpractice insurance, as an example. So I hear what you're saying about the success rate not being very high, but at the end of the day, that doesn't mean a physician's malpractice insurance is going to reflect that probability.
Yep.
How do we change, one question here, how do we change the culture for patients who believe that they need extra services and insist on them? We've all heard stories of people watching, as an example, we're not talking about this today, but a prescription drug being advertised on the television, and then they go into their physician next week and they ask for that prescription drug. But I guess the question here is, would requiring some level of co-insurance for all the procedures that someone were asked to take advantage of, would that be a way in your mind? Or is there some way of helping the patient to actually change their overuse or demand for those services?
Well, I mean, I think this is where both education and benefit design and transparency, merge. And, we have had great access to healthcare in this country for many people, not for everyone. And we've been very insulated from the costs historically, and that's all changing. But that has led to, a Me Too kind of attitude. And I think that a combination of education, of benefit design that is catered to, better coverage for things that are important for the patient to get, and, more differentiated coverage for types of services that may be elective or may, be overused, can help focus the attention of patients, as well as transparency about prices and quality and education along with it. One of the things that we've been pushing for example, as the number of health plans and vendors offering price transparency tools grows, is that when people do searches for services that we know are overused, that they should be flagged, and there should be messages that pop up that give statistics about how often these services are overused, and that you should question your doctor on whether you really need them. So that's an example of pulling these things together. And then imagine if there was a reference price on top of that, where patients would have to pay out of pocket above some cap on the coverage for a service that is often overused, that would also focus the attention of the patient more carefully. So I think there are many things that we can do that brokers can really help advise their customers on that would require a patient to pause and to really consider options before moving full steam ahead.
So another question came in saying, to implement these ideas, do you think that we're going to need legislative action by Congress, or do we hope that the provider industry will do this on their own? So similarly speaking, like we talked about out in Oregon, how do we share the story of what the Oregon marketplace did, and then ultimately have other provider groups who are dominant in other areas in the country behave the same way? Do you think we'll have to do that through Congress enacted legislation, regulation, or do you think there's an opportunity for stories like that to emerge and be shared across the country, and then that best practice to be followed?
Yeah, I mean, I'm not an anti-government person, but I don't see a big role for government here in sort of legislating how healthcare should be delivered. I think that through the Medicare program, it's making progress in terms of identifying quality measures that have to be reported by providers. There's public reporting on those measures. There's payment tied to those measures. And I think the commercial market is following suit, as is Medicaid. So I think that the marketplace itself has so much more to explore than it has done so far. I don't know exactly what the role of government would be here. I think government can play a role in insisting on transparency. And, we just recently put out our third annual report card on state price transparency laws. And, it shows that some states have made huge headway, like New Hampshire, on making sure that citizens have access to price information along with quality information. Other states have done very little. But I think when it comes to trying to pressure providers to adhere to guidelines, I'd like to see it done much more through performance measurement, public reporting on that performance, and payment tied to that performance. I think that's going to get the attention of providers and allow for, updates in clinical guidelines that, it might be hard for government laws and regulations to keep up with.
Yeah, I think you referenced what can the government do. I mean, CMS, if I'm not mistaken, just rolled out bundled payment for hip surgeries, correct? Am I mistaken about that? Okay. So there's an example where the government's leading in a different payment-type model. Can you talk a little bit about that? What's happened?
Yeah, I mean, I haven't had time to delve into the real detail of that program yet, but it's a huge deal because bundled payment has been talked about. There have been more conferences on the subject than there have been actual bundled payments because it's really tricky to implement. And, for most of the commercial health insurers, they have to manually process bundled payments because they haven't built the claim systems yet to allow for it to be automated and really scaled. So the fact that Medicare is instituting bundled payment, in many, many locations for hip and knee replacements is going to help providers at least put on their training wheels, when it comes to understanding how to process this. Medicare will certainly learn from it. And like with everything with Medicare, the commercial market often follows suit. So I think it's going to create some great momentum around a method of payment that has been shown over time to not only help improve quality, but also help contain costs.
Last question here. How do we determine which services, procedures, and testing are inappropriate? And then how do we determine the consequence for people who still receive that care?
Yeah, it's a great question. And
it is a great question.
You made an interesting comment before that you think that healthcare is more science than art. I think that's debatable. I think we know so much now, but there's also so much we don't know. And so there's always going to be gray areas here without question for as long as any of us are alive. So I think, I just lost my train of thought. Mark, what was the question again?
So how do we determine which services, procedures, and testing are inappropriate?
Thank you. So sorry about that. I was so caught up in what I was saying that I forgot what you asked me. I think the bottom line is that there have been, in certain areas, big enough studies done that show, on average, for a patient to receive care in a certain way will be more likely to lead to positive outcomes. So where we have evidence like that, where the specialty societies and primary care physicians have come up with guidelines, I think on average, we know that patients will be better off if those guidelines are followed. There are many, many areas for which there are no guidelines, and there are many areas for which guidelines probably need to be updated. And this is an ongoing struggle. So I think it's not black and white. It is perhaps as much art as science in some areas, but in some areas we really do know the science pretty well, and where that exists, we need to follow it.
Excellent. And I lied. We got one more question in. How can employers be a part of the mix in helping their employees make the right decisions? So I know benefit design would be a place that you could start, but what else do you think employers can do to help their employees?
Yeah, I mean, I think it's got to be a combination of education, the right incentives through benefit designs, and the right relationships with, the health insurers they choose to work with and the providers that they contract with. I think, obviously this audience knows better than I do how much this marketplace is changing. I think in some markets maybe it doesn't feel too different yet, but in other markets it feels very different. I live in California, and the advent of the marketplace here covered California has led to, a tremendous number of new products on the market where there are a narrower band of providers available to someone who selects those products. And, to the degree that those providers are chosen based on both quality and cost, and there is some steerage toward them with the benefit design, I think that employers could do a lot in offering something like that to help direct their employees when they're patients to the right providers to get the right kind of care. But it requires measurement of adherence to guidelines. It requires accessible information on how good that adherence is. It requires, payment reform to get the providers to keep improving. And then it requires education, transparency, and benefit design, which is, probably the most under the control of the employer to get the population, moving toward the right type of care and demanding the right type of care.
Excellent, Suzanne. Thank you very much. And that concludes our Q&A portion of our webinar. Suzanne, it's been a pleasure. 6 out of 10. Our next one will be on Wednesday, August 26th at 1 o'clock. And we're going to talk about how to assess your local market's prospects for payment reform.
Well, Mark, thank you so much. It's been a pleasure as usual, and I look forward to any questions that people have following up after the webinar.
Great. Thank you very much, and hope everyone has a wonderful day.
Thank you very much, Ms. Delbanco and Mr. Gagne. We also thank each of you for participating in today's program. This concludes Webinar 6, Curbing Inappropriate Care, presented by the National Association of Health Underwriters Education Foundation. Thank you again for attending. Have a great day, and you may now disconnect.